Good evening everyone. Today the topic of presentation is diarrhea. First we'll split this into two topics. One is acute diarrhea and then we'll discuss about the chronic diarrheas. So we see in day-to-day practice a lot of cases being admitted or coming to the OP basis with the complaint of diarrhea. So first we'll talk about acute diarrhea. So before going into the what is acute, what is chronic, we'll define what is diarrhea. So diarrhea is defined as anything more than 200 grams per day of stool from in a Western diet on a patient on a Western diet that is defined by Harrison's. That is there in the Harrison's more than 200 grams per day patient on Western diet. But WHO defines it as more than 3 stools per day which are liquid or more than normal frequency what we pass is considered as diarrhea. So, as per Harrison's, anything more than 200 grams per day for a person who is on a Western diet is considered as diarrhea. So, how it is differentiated acute, chronic is diarrhea? Acute diarrhea is anything less than 2 weeks. 2 to 4 weeks is considered as persistent diarrhea, and more than 4 weeks is considered as chronic diarrhea. So, first we will talk about acute diarrhea. Then in the next session we will discuss about the what are the causes of persistent and chronic diarrhea in the next session. So acute diarrhea, most of the causes, 90% causes of acute diarrhea are mostly infective in a day, we see in a day-to-day practice. So most of the cases are related to infection. So this discussion is mostly about the, as I say, acute diarrhea. There are some causes of acute causes of diarrhea which are non-infected, but most of them related to the infection-related causes. So in this session, we'll learn about when to start anti-motility drugs, when not to start, when to start antibiotics, when not, for whom not to give antibiotics, because every diarrhea should not be given antibiotics. For every patient we need not give anti-motility drugs. So like we always do, we go on a case-based approach. So a 28-year-old female traveling from United States to India developed diarrhea which is watery and 4 to 5 episodes per day at large volume for 2 days. So as I said, so this is a when we go into the symptomatology of diarrhea also, we need to understand two different things. One, whether it is small bowel or a large bowel diarrhea. So what is small bowel diarrhea? Small bowel diarrhea is a large volume diarrhea where the frequency is less and it is not associated with any tenesmus or pain, or generally not associated with any blood also. And also it is more of large volume and small frequency, and it is generally associated with some other any malabsorption or any weight loss if it is present for chronic symptoms. But large bowel is more associated with, because of the rectum involvement, has more of pain, blood, mucus stain, and more frequency because of that. It stimulates rectus, it causes tenesmus and urgency in, and there is difficulty in defecation also, and it is small volume but frequency is more. That is how here you can see the patient has diarrhea which is 4 to 5 episodes per day, not much of, like 4 to 5 is okay, and large volume. So this is morely looking like a small bowel diarrhea. So he patient recently traveled from United States to India. So there is a travelers, there is called travelers diarrhea. Travelers diarrhea is mostly related to E. coli, enterotoxigenic E. coli. It produces a toxin, it produces diarrhea. So, so how do we go about this patient? So what generally we see is whether we go and start ahead an anti-motility drug and antibiotics straight away or not. It based on the condition. So first thing we need to understand, there is a history of travel history that says there is a travelers, mostly because of the travelers diarrhea, that is common. And also it is a small bowel diarrhea because there is a large volume, small frequency, not also with any tenesmus or mucus or blood. So and also whether we start antibiotic or not is based on the how much significant is there. So diarrhea is again divided into mild, moderate and severe. Mild diarrheas are anything less than about 3 stools per day. Anything 4 to 6 is considered as moderate, and more than 6 is considered as severe. So here is patient is having a moderate kind of diarrhea. If it is affecting, if it is travel or anything, it is considered moderate area. Severe is anything affecting his day-to-day activities also. Mild is something it is not restricting any of his activities. So anything less than 4, around 3 which is not restricting any activities mild, and 4 to 6 where the patient has some restriction in travel and he was not able to travel and has 4 to 6. More than 6 is significant, it is affecting. So generally initially we start the patient with oral ORS fluid therapy and electrolytes replenishment and all those therapy. You can add some probiotics. Probiotics are generally proven to be more effective in the case of pediatric age group. We try them in the adults also, because what is the mechanism behind it is it promotes the growth of healthy organisms and suppress the violent. Whether we start anti-motility drug or not and antibiotic is that for milder cases we need not give antibiotics, because antibiotics can calm more. It kills the normal gut bacteria also. The patient is mild and patient is not having any significant symptomatology. Patient can be managed with proper symptomatic management like fluid support and all you can give. So the patient has a significant diarrhea, you can add loperamide or bismuth salicylate along with oral antibiotic like ciprofloxacin or rifaximin or azithromycin cap. This is looking like a more like a moderate diarrhea where you can add oral if the patient is complaining, like he's having, it is restricting his day-to-day activities. You can add an oral loperamide or bismuth salicylate along with oral ciprofloxacin. If the patient has any around 3 to 4 episode, does not restrict, it is not bothering, you can just give ORS fluid and just send him home. And you can actually give him bismuth salicylate or something for his motility. So do we routinely give for all the patients the anti-motility drug or not is the question. Antibiotic is not. So what happens is there are actually two kinds of diarrhea. One is non-inflammatory and inflammatory diarrhea. So I'll come into the discussion later. Generally, non-inflammatory diarrhea is when the toxins and viruses, like toxin-producing bacteria and viruses, cause diarrhea, where the bacteria does not invade the intestinal mucosa, so it doesn't cause any much of inflammation. So non-inflammatory diarrhea is generally like any bacillus cereus or staphylococcal toxin or any toxin producing. Sometimes they can cause diarrhea where it starts with vomiting and they don't have much of fever or anything. So you can actually like food poisoning, like you seen after you eat Chinese food you have vomitings and diarrhea which subsides on its own. So in those patients you can actually give anti-motility drugs. The antibiotics are generally not needed in them. So generally they subside with in 1 or 2 days. So in them the non-inflammatory diarrhea, especially toxin producing diarrhea, mostly you can they have more of vomiting and diarrhea syndrome. They don't have much of pain abdomen or something. They don't have high grade fevers also. Whereas unlike in the inflammatory diarrhea where the pathogen is attached to the intestine and they cause proper invasion and can cause intra-invasive bacteria, intra-invasive E. coli or intrahemorrhagic E. coli, or sometimes Shiga toxin also can be invasive sometimes. So Shigella can also be invasive, and Salmonella can be invasive, Yersinia can be invasive. In them they produce more amount of fever and also abdominal pain and much less of nausea symptoms. So in those patients, the thing is, if you give loperamide or something like that drug, it delays the recovery from the patient. So in them patients you should use with caution anti-motility drugs, because the patient where the bacteria is affecting the intestinal epithelium, so if you give anti-motility drugs it will prolong the disease duration and delays the recovery. So in them, regarding the antibiotic usage also, we'll discuss on the further case-based scenarios, and also we'll have a different understanding from each case to case. So this is a case of traveler's diarrhea where you can give, like there's a classical history of the patient traveling from USA to India, and also the small bowel diarrhea, enterotoxin. You can give mild symptoms, you can manage with the ORS fluid. For moderate, you can give oral antibiotic along with loperamide, or you can give bismuth salicylate also. And for severe, definitely you should give. So a 45-year-old known case of RVD presented with diarrhea since last 7 days. So in this case, like in a case of RVD positive case, generally he's an immunodeficiency case. So whether you give antibiotics, whether you not give antibiotics, the diarrhea, generally RVDs can have both small bowel or large bowel diarrhea because they're immunodeficiency. You remember one thing, all the parasites, Cryptosporidium, Microspora, Isospora, everything is small bowel. There are only 3 causes of large bowel diarrhea. One is CMV, other is histoplasma, like third is C. difficile. So in the HIV, the common causes of the large bowel, remember the large bowel, rest are all small bowel, large bowel, CMV, histoplasma, and the other is C. difficile. So other than that, most of them are small bowel diarrheas. So whether we give antibiotics in this case or RVD is immunocompromised, any patient, elderly or immunocompromised, has a valvular heart disease, or a patient who is having significant immunodeficiency, generally need to give antibiotic therapy so that to prevent the significant sepsis or sepsis related complications in them. So we give antibiotic therapy in this, and most of the causes in RVD positive are mostly viral related or parasite related. Bacteria also needs to be covered. So you need to send a stool for ovocyst. You find if any is Cryptosporidium or Isospora, Microspora, you need to give appropriate therapies for them. So Cryptosporidium generally can be managed with the antiretroviral therapy. It doesn't need any significant separate antibiotic for that. It's an antiparasitic drug for that. So other than based on the which parasite that grows, we can give appropriate therapy. In that patients, you should always look for CMV also. CMV serology also, and you need to do a colonoscopy to look for any like any ulcers are there, or CMV related colitis is there or not. You need to do all of that in HIV patient. You need to start them in antibiotics, look for stool for ovocyst, and also get a colonoscopy to look for any C. difficile is there, CMV is there, any other ulcers, any other ulcers that has pathology, and entamoeba histolytica can cause large bowel. So you can look for that specificities in that colon and colonoscopy, and based on that you can plan. Initially you need to start them on prophylactic empirical antibiotic, titrate the ART therapy based on the proper parasitic growth that is there. You can add metronidazole or nitazoxide oxide based on the parasite. I'll discuss about the what parasite, what drug should be given in the next in the treatment part. So in this is the so all immunocompromised elderly, any valvular heart disease, any transplant patient, you need to give antibiotic therapy so that they won't go into multi-organ failure and severe sepsis. So a 14-year-old kid present with fever and bloody diarrhea since 3 days. So what is this case? Like fever and bloody diarrhea since last 3 days. So you might be thinking that the fever and bloody diarrhea is there. So you might think a large bowel diarrhea is there and a fever is there. So mostly it is an invasive, like inflammatory kind of diarrhea where some organism is infecting the intestinal epithelium. That is true, because fever is most commonly seen in the inflammatory diarrheas rather than non-inflammatory, where most of them are non-inflammatory or viral related like rotavirus, norovirus, or and also some toxin producing organisms. Whereas in like fever is most common in salmonella, shigella, enterohemorrhagic E. coli, and in these cases where the intestinal epithelium is affected, you see fever. Bloody diarrhea is one more that is suggestive of invasiveness and large bowel diarrheas. So this patient might be having salmonella, that can be shigella also, that can be entamoeba histolytica also, and also some parasitic can cause, even enterohemorrhagic E. coli can present with this kind of picture. So do we routinely give antibiotics for this patient is not is a question. So some things you might have already heard, so that Shiga toxin producing E. coli and enterohemorrhage, like these causes can cause, in those antibiotics are contraindicated because it can precipitate the HUS because they can provoke the toxin production. So this patient is having fever and bloody diarrhea since last 3 days. In this case of patient, definitely we don't give anti-diarrheal drugs routinely. We generally start them on empirical antibiotics, because maybe, so there are two conditions where we generally don't go and start right away antibiotics. What is Shiga toxin producing E. coli and also enterohemorrhagic E. coli. In two of those cases, generally fever is not present. They are febrile dysentery. So generally the fever is not present in them, they are dysentery. That is one of the classical presentation of a Shiga toxin producing E. coli which can precipitate the HUS. In them, bloody diarrhea is there, fever is not there. So when there is no fever and bloody diarrhea is there, you should not start them an antibiotic because there is a risk of HUS, and it is also more of epidemic. Most of it comes like the whole school is like a people around their houses, or like a class in that house. Most of them come as an epidemic where they, in that case also you should think twice before starting an antibiotic. Most of them are having bloody diarrhea with no fever and all. But in this case of fever and bloody diarrhea, this is more of a inflammatory diarrhea. You need not start them an diarrheal drug or something. You can start them on a empirical antibiotic that can be fluoroquinolone, like ciprofloxacin or something, or you can add a macrolide also. Based on your institute protocol, you can add a fluoroquine, ciprofloxacin, or ciprofloxacin is what we generally use, 500 mg. You can start them. So then you can send a stool for oocyst and stool for blood bacterial culture based on the specific pathogen that is associated. You can plan on the treatment. So so that is how you go. Any patient with fever or any bloody diarrhea, if there is significant severe diarrhea, or if the patient is having persistent diarrhea for more than 1 week, you need to consider starting an empirical antibiotic therapy and sending a specific pathogen. In routine watery diarrhea where there is no blood, there is no fever, you can generally wait for symptomatic management and see how that goes. A 29-year-old pregnant female presented diarrhea which is present for last 7 days. So this is a 29-year-old female. Why I presented this case is, this is a case where generally pregnant females, I want to highlight the point that when any patient present with pregnancy is like one of the characteristic infections in a pregnancy diarrhea is listeria. So listeria cases generally we don't see in a routine day-to-day practice in other cases, but that is the one thing I want to highlight in this case. A pregnant female present with diarrhea, you should always suspect listeria. So I want you guys to tell what is the treatment of listeria. I'll be happy if you tell, otherwise I'll mention it in the next session. Listeria, what are the manifestation, what is the treatment listeria? This is the one question I highlighted because in pregnant female I want to tell listeria is a common thing. That's what I wanted to tell. A 38-year-old man presented to OPD with complaints of weight loss and diarrhea and his history of drinking unfiltered water. So there are some kind of chronic diarrheas where the patients have weight loss, vitamin A deficiencies and all, and this is a chronic thing that is and there's unsanitized water, which is unfiltered water. So this is mostly related to, most of them are parasitic. This comes under most of the chronic diarrhea. I think it's most common as a parasitic. One of the most common infection that can comes from the unfiltered water. This history, unfiltered water, whether they have sprouts, like the sprouts are seen most commonly with sugar toxin producing E. coli. Poultry eggs is seen in salmonella. So you need to remember this catch word: fried rice, bacillus cereus. So canned meat. These are all you need to look them so that they are the catch points. What kind of food they ate was also important in the case of infected diarrhea. That is one thing I want to highlight. There are some catch points in the history. So you need to remember them so that you can treat them better. So this is a 38-hour female unfiltered water that is suggestive of giardia. Giardia is seen in the small intestinal diarrheatism. It's present in the duodenum. It can cause weight loss. It can cause chronic diarrhea also. It is generally treated with metronidazole. So this is the case of giardia. This I want to highlight the importance of these small history points. What kind of is the precipitation? Whether they ate, what kind of food they ate, what kind of food habits is very important in the case of treating infective diarrheas. A 22-year-old male developed the vomitings and diarrhea after eating. Again, that's eating Chinese food. Chinese food is one more thing that can cause, like within, like based on the duration also. Generally 1 to 6 hours we generally see with vomitings and diarrhea. It is generally 1 to 6 hours. Is generally bacillus cereus is the most common thing that is seen in fried rice. So bacillus cereus is one of the most important thing that you need to keep in mind. So bacillus cereus is one thing. Generally, it is generally symptoms resolve with the symptomatic manner, that is fluid replacement, and you can give some antiemetics and antidiarrheal drugs that will subside. In the case of small non-inflammatory, you can try to give like in the toxin producing, or some toxins are preformed toxins, some toxins are produced inside the intestine. In them, you can try and give some loperamide, so that because the organism per se is not, the toxin is the one that is causing. You can try anti-motility drugs and them in them. So this generally symptomatically managed can be is okay with this. The patient is need not might not require an antibiotic therapy and all. They are mostly managed symptomatically. 65-year-old female hospitalized for 1 week now developed diarrhea which is non-bacterial, not responding to antibiotic. So one of the most important thing is the patients who are chronically hospitalized in our ICU setups will be on some or the other antibiotics. Like the patient will be put on multiple antibiotics for one n number of reasons. But my patient may be having a meningitis, patient might be having some UTI or something. So in them the most important thing is, and then the most important thing you need to remember is always it's like any patient who is hospitalized in the last 3 months has been using antibiotic, like in the last 3 months, if there is any use of antibiotics or something in the last 3 months, or hospitalized for more than 3 days, you should always suspect C. difficile when they are not responding to the, and routinely also you should suspect C. difficile when they are not responding to routine antibiotic drugs or coverage or anything. So this might be a case of C. difficile where the patient, you should need to take your stent for C. difficile, toxin A and toxin B, and need to get a colonoscopy also done to look for any pseudomembrane. So any hospitalized patient who are on the chronic prolonged antibiotic therapy, or patient who is hospitalized for more than 3 days and some antibiotics in the last 3 months also, if there is usage of antibiotic therapy in the last 3 months also, if there is a hospital admission, you need to always suspect C. difficile therapy, where they classically present a small bowel diarrhea. Though it is a large, C. difficile is a large bowel thing, they classically present as a small bowel picture, like the patient of having the watery large volume diarrhea, small frequency. So it is present as a small bowel diarrhea. So in this case, this is C. difficile, in which you give, previously they used to give IV metronidazole. Now the first line is always oral vancomycin. If there is any severe diarrhea and the patient is having fulminant, you can give both oral vancomycin along with the IV metronidazole. So if there is a recurrence, there is a different dosage regimen. You can titrate the oral vancomycin. I'll explain the treatment part later. You can titrate the oral vancomycin treatment again. Also, you can go for fecal microbial transplant also. So you need to remember, any hospitalized patient on the prolonged antibiotic, you should not always suspect there is a possibility of C. difficile. You need to get a colonoscopy done. You need to get a C. difficile toxin A and toxin B done. A 35-year-old male alcoholic developed a bloody diarrhea with increased frequency and small bowel associated with pain in defecation. So you can see this clearly. There is increased frequency, small volume associated with pain in defecation. There is a classical history of large bowel diarrhea. He is an alcoholic. Most probably this is a case of entamoeba histolytica. So entamoeba histolytica is a classical large bowel diarrhea where you find you already know it causes a large bowel diarrhea. It can cause intestinal amoebic colitis and also cause liver abscess. So the treatment part varies. Most of the times when we see the patient in our OPD based on when they're amoebic liver abscess, we just give metronidazole and send them home. That is not how it should be done. Though there are different class of drug in treating the entamoeba histolytica. So the thing is, when you're giving the metronidazole, it only works at the tissue level. It doesn't work at the intestinal level. So metronidazole, whatever you are giving for the hepatic abscess or liver abscess or something, that works for that, but it doesn't remove the intestinal entamoeba. You need to give for that paramomycin along with that. So that is one of the most important. When you give metronidazole, you should always follow up with giving for at least few days of 3 days of paramomycin should be given to clear the luminal amoebiasis present in the intestine. So that is very important. In this patient, if the patient is having only luminal amoebiasis, there is no much of inflammation in that, you just give paramomycin and leave. If you think the patient is a tissue invasion is there, some liver abscess, you give metronidazole and paramomycin. Always remember in your daily practice, just giving metronidazole is not enough in a case of liver abscess, which you think is amoebic liver abscess. So in them, you should give metronidazole first for at least 7 to 14 days, then followed by at least 3-day course of paramomycin should be given, so that they'll clear both intestinal and also per hepatic level. That is always. If the patient has just having GI symptoms, not much inflammation, no high grade fevers has begun, you can just give only luminal idoquinol or paramycin can be given for 3 days and just leave it. So that depends. And also when you send amoebic antibody, you just, that is generally positive when the patient has tissue injury. That is when there is some liver abscess or there is intestinal inflammation, inflammatory diarrhea is where then the stool antibody is positive. If just histolytica is present just in the lumen, it is not invading the intestinal, then the stool antibody won't be positive much. So the liver, in the case, mostly in the case of liver abscess, there the antibody positivity is significant. In normal area, it is not much severe. You need to get a colonoscopy and look for the flank shaped ulcer, flash shaped ulcers or something. Generally, because stool antibodies and the serum antibodies might not be positive in the case of if there is antibody is not invasive and present in the tissue. Generally, only tissue or hepatic abscess, liver abscess can have a significant antibody positivity. A 30-year-old female admitted for community-acquired pneumonia was treated with ampicillin, developed diarrhea after 3 of admission. So this is one of the things the patient was treated with diarrhea for the ampicillin for community-acquired pneumonia. Now developed diarrhea of 3 days. Initially he has no diarrhea. She has no diarrhea. Now developed diarrhea after 3 days. So so this is not one thing always. Should always suspect C. difficile because of that. But one more thing, ampicillin itself can cause diarrhea. So you should always remember sometimes the drugs itself can cause diarrhea. Like NSAIDs can cause diarrhea. The ampicillin, some broad spectrum, many of the broad spectrum antibiotics can cause diarrhea. One of the most examples, ampicillin can cause diarrhea. Some calcium channel blockers can cause diarrhea. The routine we give in the PPA therapy can cause diarrhea. Magnesium which we give, sucralfates we give. These all can cause diarrhea, which at least especially magnesium containing therapies can cause diarrhea. You need to remember all this. Some lactulose which we give in the hepatic encephalopathy, they can cause diarrhea. So you should always remember these points. And at least sometimes drug related thing, some broad spectrum antibiotics when you are in NSAID. So sometimes they are non-specific diarrhea. They are not significantly associated. If there is no some significant fever spike or there is no significant elevation in TLC count, they just develop diarrhea. So always look for any drug related cause, especially when you recently started them an antibiotic or some calcium channel blocker, some magnesium containing drugs, some lactulose. So you should always keep them, maybe they are the cause of the diarrhea. When there is a patient is not having significant fever spike or no TLC elevation, not significant, only mostly look like small volume diarrheas and all. So you should look for that cause, and maybe if you stop the drug, maybe the patient diarrhea will subside. So drug cause of diarrhea also should be looked for. So that is the question. Now we will go into I understand most of the cases are mostly infective, but acute diarrhea, you should understand what are the causes of infective diarrhea, how do you treat them, how do you go about them. So diarrheas are generally classified into non-inflammatory and inflammatory. Non-inflammatory are usually viral. Some of the toxin-producing diarrheas are also non-inflammatory. Inflammatory are generally invasive or toxin-producing. Some toxin-producing diarrheas are invasive also. So these non-inflammatory diarrheas generally don't invade new circulation. They just stimulate the intestine to secrete they are mostly they stimulate the intestinal secretion, so that it is a secretory kind of diarrhea. But inflammatory, they disrupt the intestinal epithelium. That is one. So non-inflammatory, they have nausea, vomiting, generally don't have significant fever as I told. But inflammatory have fever, mostly fever, abdominal pain, and also bloody stools. That are the classical symptom of inflammatory diarrhea. And this is the thing. You stand for stool for leukocytes, no? That is the difference. So generally stool for leukocytes is positive in the case of inflammatory diarrheas where there is a disruption of inflammatory mucosal integrity is there. So generally stool for leukocytes cannot differentiate between fecal, infective and inflammatory also. Sometimes ulcerative colitis, Crohn's disease, they are also inflammatory diarrheas. They are also stool leukocytes, but that doesn't differentiate between inflammatory and infective. One of the other marker that can be used, lactoferrin, can also be used, which is a marker of leukocytes, that can also be suggestive of inflammatory. So this is one of the absence of fecal leukocytes suggestive of non-inflammatory diarrhea, whereas presence leukocytes. So any absence, you can look for viral causes. Some toxin producing bacteria, they can cause a non-inflammatory. So generally, non-inflammatories are generally mild, generally symptomatic management, whereas inflammatory are more severe. They might require antibiotic therapy. Common pathogens of non-inflammatory are E. coli, C. Clostridium perfringens, Bacillus cereus, Staphylococcus aureus toxin, rotavirus, norovirus, giardia, so cryptosporidium, vibrio cholera. So these are all non-inflammatory kind of diarrhea. Inflammatory are more of invasive, like salmonella, shigella, shiga toxin E. coli, intro-invasive E. coli, Class C. difficile, Entamoeba histolytica. So Yersinia is invasive. So if you can remember them, the list is very good. But you remember one thing: all viruses are non-inflammatory, and most of the toxin, like toxin, enterotoxin E. coli, or Staphylococcus aureus, BCAS, which we commonly seen as a food poisoning, they're all non-inflammatory diarrheas. That's good enough. And salmonella, shigella, enterohemorrhagic, anyways, remember as inflammatory diarrheas there, because they're very invasive. So that's all you can remember that. That's good enough. So these are again the example that we given the Harrison's, where non-inflammatory is mostly enterotoxin, inflammatory where there is invasion or some cytotoxin that is produced inside the cell of the intestine. Again the same example, non-enterotoxin producing bacteria, like you can remember this way also. Enterotoxins, we know Vibrio cholera is enterotoxin, enterotoxinogenic E. coli is enterotoxin, so enteroaggregate E. coli, which is called one of the travels diarrhea, Clostridium, where the toxin is produced in the intestine, whereas cytotoxins are produced inside the intestinal epithelium. So that way also you can just all of the viral are generally enterotoxin, like non-inflammatory diarrheas. Inflammatory diarrheas are mostly Shigella, Salmonella, enterohemorrhagic, E. coli, Yersinia, Listeria, and Vibrio parahemolyticus, C. difficile. So these are all enter where the patient needs to, organism needs to invade into the mucosal integrity, break the mucosal integrity, enter the cell, then produce a cytotoxin. So penetrating salmonella, E. coli, this is distal small bowel. So inflammatory diarrheas are generally colon or distal small bowel, whereas non-inflammatory are mostly proximal small bowel. So you can remember all of this list, like Vibrio cholera, E. coli, which is common in traveler's diarrhea, all Bacillus cereus, Staphylococcus aureus, which we commonly, so all viral, most of all viral cases are proximal small bowel. All these causes, they are mostly water diarrhea. All inflammatory like salmonella, shigella, Entamoeba histolytica, any Shiga toxin E. coli, all Yersinia, Listerias, all C. difficiles, all parasitic. Most of the parasites are like Entamoeba histolytica. These are all distal, where the dysentery inflammatory bowel is there. So this Salmonella Yersinia is also small bowel. This is also present as inflammatory kind of diarrhea. So that is one of the important thing. So this is one of the main differentiation, if you can understand. Non-inflammatory are mostly watery diarrhea, where they are more proximal, and most of them are viral or enterotoxin producing, whereas inflammatory are mostly distal small bowel or colon, where they are producing having high grade of fever. They won't have, they more po in abdomen, whereas non-inflammatory doesn't have much of fever. So that is more important that I want to highlight again. So this is the differentiation again: small bowel, large bowel. Small frequency is normally slow, normal, whereas frequency is increased in large bowel because of the rectal stimulation. There is urgency. Fecal volume is increased in the case of small bowel, whereas normal decrease in large bowel. Mucus is generally present in the large bowel. Fecal blood is hematochezia is present in the large bowel, whereas melena, black colored stools. Tenesmus is where the rectal urgency, that is tenesmus, is present in large bowel. Urgency is more present in large bowel. Vomitings can be present in both. It depends on the cause. Steatorrhea is mostly present in small bowel because of the malabsorption. Dyschezia, that is difficulty in defecation, that is present in large bowel. Weight loss, if it is present in chronic diarrhea, it can cause small bowel, cause weight loss. But large bowel generally doesn't cause weight loss in the case. So this is one of the small bowel is more of large volume, small frequency, not also with any mucus, blood or tenesmus or urgency. Whereas large bowel is more of small volume, increased frequency, increased tenesmus, increased mucus, increased blood. So that is the most important differentiation you need to know. And I also tell what are small bowel and large bowel. Most of the small bowel, proximal bowel are non-inflammatory diarrheas, whereas large bowel diarrheas are mostly inflammatory, enteroinvasive, and diarrheas like Salmonella, Shigella, Campylobacter jejuni, Entamoeba histolytica, Yersinia. These are all mostly small bowel, distal small bowel to large bowel. Proximal small bowel are mostly viral and traveler's diarrhea and Staphylococcus aureus, Bacillus cereus. These are all things. So this is again the important example where the first any patient presenting with the acute diarrhea less than 2 weeks, so more than 3 frequency per day or more than 200 grams per day, the definition itself says that. So ischemic patient, especially who are presenting having some like I'll give an example: a 50-year-old male who is a chronic smoker, who is chronic already has history of CAD and CKD and has a dyslipidemia, now presented to come abdominal, now presented with the complaint of abdominal pain and diarrhea, and has a initially watery diarrhea, now has a bloody diarrhea. You should always suspect acute mesenteric ischemia. So they are at very high risk of acute mesenteric ischemia, especially who has significant CAD history, CKD history, dyslipidemia is there, diabetes is there, now presenting with pain abdomen, initially watery diarrhea, then bloody diarrhea. You should always suspect the acute mesenteric ischemia and get a CT angiogram done. How do you diagnose acute mesenteric ischemia? You can just go for check for serum lactates, they will be elevated because of the intestinal ischemia. So any organ that is having hypoperfusion, the lactates will be elevated. So that is a basic physiology. We can septic shock also. Any shock we check lactates because any hypoperfusion causes lactates elevation. So initial screening test, if you are suspecting that, if you are getting CT angiolate, you can get a ABG done, check the serum lactates. If they are elevated, there is a chance patient is having intestinal ischemia, that might be acute mesenteric ischemia also. So that is the closest differentiation. Any patient with significant CAD, CVD or peripheral vascular disease history, diabetes, hypertension and all is there, now present pain abdomen and bloody diarrhea, you should always suspect acute mesenteric ischemia. Infective is already said small, but usually watery diarrhea due to toxin release. Can be cramps is present. They're mostly viral and bacteria. I already mentioned the cause. I don't want some drugs and toxins also, mostly small bowel diarrhea. Large bowel usually bloody diarrhea due to tissue infiltration. They have tenesmus urgency, bacterial Campylobacter, Shigella, Salmonella, enteroinvasive or enterohemorrhagic E. coli, and Shigatoxin producing E. coli, or C. difficile is there, Entamoeba histolytica. They're all linked. But in HIV, I will again repeat again, all Cyclospora, Microspora, Cryptosporidium, they're all small bowel diarrheas. Large bowel only CMV, histoplasma and C. difficile. So another nausea and vomiting, most of generally the food poisoning patient with nausea and vomiting, they're mostly bacillus, they're serious, they generally managed benign, not much of antibiotics is symptomatically managed. Inflammatory, we'll discuss in the chronic diarrhea part again about the ulcerative colitis and Crohn's disease. I'll again discussion, and you should always remember this dietary consideration also. Some patients who are having constipation, they take a lot of fiber food and a lot of fat ingestion also. They take, like patients who are taking a lot of fiber and a lot of fiber and fat ingestion. Sometimes they take non-absorbed sugar, like in the form of gums or something. They also will have diarrhea. So you should ask for that history also. Some patient will consume excess of fiber food also. You should ask for that history also. Now I'll ask you a question. What is fiber food? You advise fiber food. No, what is exactly a fiber food in this? What exactly do you think is a fiber food? So go and find what is fiber food per se. What do you advise a patient in constipation for fiber food? What is the kind of fiber you advise? You check and get back and answer me if possible. So in those patients also, taking anything in excess, because fiber is generally not absorbed, that can cause diarrhea. Fat, if it is not absorbed, that can cause diarrhea. So I'll again discuss in the chronic diet. I'll mention that also needs to be taken. In the dietary history, you need to ask if there is any change in diet, in excess fiber they are taking or excess fat they are taking. If they're consuming a lot of ghee or something, like any fatty food they recently consumed that cause diarrhea, you should always look for them. But if you in that you can, if you stop that thing, then maybe the diarrhea will do. The dietary things also will cause. So that is called osmotic diarrhea. So now from this you know there are two kinds of diarrhea: secretory diarrhea and osmotic diarrhea. So all of the infective cause of diarrhea are generally secretory diarrhea. Osmotic diarrhea are generally due to malabsorption or some excessive fiber diet or something. So how do you differentiate between osmotic and secretory diarrhea? So osmotic diarrheas are generally, if you put the patient on NBM, the diarrhea will subside. Because osmotic is due to not because of the intestinal stimulation, because of the food we are giving, which is not malabsorbed, that is pulling out the water from the intestine, that is causing osmotic diarrhea. So if it stops with fasting, that is osmotic diarrhea. If it doesn't stop with fasting, that is secretory diarrhea. Generally volume of stool is very less in the case of osmotic, very small bowel. Where in the case of secretory diarrhea, because of continuous the large bowel diarrhea is there, and stool sodium chloride are also very high. And stool pH is generally low in the case of osmotic. The stool pH is very high in the case because of the excess secretion of bicarbonate and all. Bicarb electrolytes are being secreted. That is, stool electrolytes are very high. So, and because of osmotic diarrhea, most of them are carbohydrate reducing substances are positive, whereas negative. How do you calculate stool osmolar gap? You calculate 290 minus 2 into sodium and potassium on the stool. If it is more than 100, it is osmotic diarrhea. Because in 290 minus 2 into sodium and potassium, I'll again mention the formula. So sodium and potassium are from the stool. So 290 minus 2 into sodium and potassium, sodium and potassium constitute most of the osmolarity. If 290 minus 2 into sodium and potassium is more than 100, that is suggestive of osmotic diarrhea. That is something other than, because sodium and potassium are not the cause. There is some other thing that is other than sodium and potassium that is causing osmotic diarrhea, that is mostly some malabsorbed, that can be carbohydrate or osmotic laxate which we give magnesium phosphate, or non-absorbed lactulose or peg or something, whatever it is, that can be cause of osmotic diarrhea. Whereas stool osmolarity is less than 50, whereas 290 minus 2 into sodium and potassium, because most of them is constituted by sodium and potassium, that is the cause of stool. That can be due to the any infectious cause or any VIPomas, where VIPomas can cause excess secretion. VIPomas will again discuss in the chronic diarrhea, or any electrolyte disturbances or any congenital enterocyte problem that can cause secretory diarrhea. So this is one thing I want to, you can calculate the stool osmolarity from the sodium and potassium from the stool. 290 minus 2 into sodium potassium, it is more than 100, that is osmotic diarrhea. If it is less than 50, secretory diarrhea. More than 100, because 2, when you are mining saying 290 minus 2 into sodium and potassium, the difference is more than 100, means the sodium and potassium are very low in the stool, that there is some other substance that is other than sodium and potassium that is causing the excess osmolarity in the that is constituting most of the osmolarity. So that is osmotic diarrhea and the secretory diarrhea. So that is one more thing I asked. Whenever there is a history, no, you need to ask the history properly in the case of acute diarrhea, so that you'll properly understand. So the first thing, which is the common Shiga toxin E. coli producing E. coli, which is cause of hemolytic uremic syndrome, where you should not give antibiotics routinely in this patient. So they're febrile and present with body diarrhea. This is one of the most important points in the nation. So any patient who is febrile and bloody diarrhea, you should suspect Shiga toxin E. coli, especially in children. In them, you should not give antibiotics. So routinely bloody stools with fever, that can be Salmonella, Shigella, Campylobacter jejuni, and C. difficile, Entamoeba histolytica, they generally associate with fever. In them, you can start them an empirical antibiotic, and then plan on the, if the specific pathogen is good, you can give targeted therapy also. So this camping, consumption of untreated water, Giardia. So fried rice, Bacillus cereus, raw ground beef or seed sprouts, Shiga toxin E. coli. These sprouts and raw ground beef is a classical history they'll mention. And one more, we got this question in NEET also. And raw milk, Salmonella, Campylobacter, E. coli, Listeria. Seafood, Vibrio cholera. Seafood, always remember, seafood or shellfish, you always remember Vibrio cholera. Uncooked beef or poultry, you should suspect Salmonella. Poultry, Staphylococcus aureus, any uncooked beef or pork, Staphylococcus aureus is one more thing. Clostridium perfection. So Salmonella, Listeria, Shiga toxin E. coli, Bacillus cereus, if you remember all this good, Campylobacter can be found in poultry. So you should all, if you possibly remember, especially remember fried rice, and one more thing, seafood and uncooked shellfish, Vibrio cholera, where they present with the rice watery stools. It is a non-inflammatory diarrhea because it is enterotoxin produced that doesn't cause much of that doesn't disrupt mucus, then the fecal leukocytes are negative, you give doxycycline. So exposure to daycare centers, where there are many people that can be caused Giardia, Shigella, Rocolation. Fecal-oral route, you can suspect Shigella, Salmonella, Protozoal. Hospital admission, you should always suspect C. difficile or treatment adverse effect. That is any antibiotic or any PPA, any laxative you are giving. You should always suspect that. So there are few things in the hospital admission thing, this uncooked beef and poultry thing. HIV, Cryptosporidium, Microspora, Cytomegalovirus, Mycobacterium, avium complex, even tuberculosis, Listeria, you should always suspect these things. In medication associated, I mentioned endocrine hyperthyroidism can cause many patients of I'll give a history where recently one of my friend told me a case where the patient presented with quadriparesis, where the patient has hypokalemia. So they evaluated what is the cause of hypokalemia. They evaluated a lot, and the patient has hyperthyroid symptoms also, palpitation, tremors, and asking the history. So the hyperthyroidism provoked hypokalemia. So hyperthyroidism can cause hypokalemic paralysis. It can cause diarrhea also. So hyperthyroidism can be cause of diarrhea. Any corticosteroid insufficiency can cause carcinoid tumors, can cause GI cause like ulcerative irritable. I'll mention about these causes later. And especially any appendix HIV, we all know this. Antibiotics, especially broad spectrum antibiotics, antacids, especially magnesium containing, any chemotherapy also I'll mention about them in the chronic thing. Any colchicine therapy, especially patient who are started on colchicine, especially for gout. Colchicine affects the cell replication, and also so it will affect the GIT is one of the most rapidly replicating cells in the body. They're replaced every few days, so colchicine affects that can cause diarrhea. So any radiation therapy, radiation associated colitis, I'll mention them in the chronic diarrhea also once again. So less commonly PPIs and NSAIDs can cause angiotensin converting enzyme. Pregnancy, I told Listeria. Persistent diarrhea with lot Cryptosporidium. And recent antibiotic usage associated C. difficile. So some causes are sexually transmitted diarrheas who are undergoing anal intercourse. They have severe rectal pain and proctor. Then you should suspect STDs also, like chlamydia, gonorrhea, Neisseria gonorrhoeae, or syphilis, or herpes simplex. They can cause anal infections also. They cause more of rectal pain, proctitis, and bloody diarrhea kind of picture. So rice water stools, Vibrio cholera, and there are some food poisonings. Like most of when we are going to the meal, most of the patients are suspected. So this is more important. Less than 6 hours, you should suspect bacterial Cyrillus and Staphylococcus aureus, where they have vomitings generally. But onset after 8 to 6 hours, 16 hours, you should suspect seed Clostridium perfringens and type A, and also bacterial Cyrillus diarrheal type. So 1 to 6 hours it is mostly vomiting type. 8 to 16 hours mostly diarrheal type. Travel to other time, travelers diarrhea, already mentioned. Most common causes enterotoxigenic E. coli. So this is one of the most important thing I want to mention. So these are the common 1 to 6 hours. I already mentioned Staphylococcus and Bacillus. They mostly present in nausea, vomiting, and diarrhea. 8 to 16 hours mostly their abdominal cramps and diarrhea. Vomitings are very rare, and they're generally Clostridium perfringens and back. This is one of the most important NEET assess question. You need to remember this. So Bacillus fried rice is important, very important. Vibrio cholera, shellfish is very important, and also uh, uh, this is Campylobacter poultry and raw milk is very important. So if you can remember these things, very good. But I don't know. It's up to you. So these are the common anti-motility drugs we'll use. The channel block that are effective in the secretory diarrheas. You can give them in the few cases when they're very severe. That is guanyl cyclase agonists like lincolnitide or plecanatide can be used. Sodium hydrogen exchange 3 inhibitors like tenapana or lubiprostone. Chloride channel inhibitors like chloride channel 2 inhibitors like lubiprostone. These are all the channel things. But most of them we generally don't give unless they're very severe diarrhea is there, because they might inhibit the, if there is it's a specific invasiveness is there, especially in the case of inflammatory where the specific invasiveness of the organism is there, they might delay the recovery in the patient. But these drugs can also be used in the irritable bowel syndrome mostly, whereas a functional diarrhea is present, irritable bowel disease there. In them you can try the some drugs of this. So this is diarrhea. You should ask for all the history, duration used. You ask for duration, fever, any stool history, abdominal pain. Is there any recent antibiotic use, any travel history? Non-inflammatory, just you give symptomatic management and no transmission. If the inflammatory diarrhea, that is any stool leukocytes, lactoferrin positive, you should culture for all the Shigella, Salmonella, Campylobacter diarrhea. And if it is there is hospital admission, recent antibiotic, start C. difficile toxin also should be evaluated. Consider empirical antibiotic. Also check for parasitic therapy. So this is the acute diarrhea history and physical examination. If it is likely infectious, mildly if there is no fluid and electrolyte imbalance, if the patient has fever more than 38.5, bloody stools are present, fecal WBC are present, immunocompromised are present, elderly host patient, then you go for stool microscopic study. If pathogen is found, you go for specific treatment. If no, the empirical treatment needs to be present. So if the patient doesn't have any of this, no fever, no bloody stools, no fecal WBC, no immunocompromised elderly host, you can go for antidiarrheal drugs. So this is one of the most important slide I am keeping. No, before starting antidiarrheal drug, always rule out there is no fever, no bloody stools, no fecal WBC, no immunocompromised host, not an elderly host. Then you can go for antidiarrheal therapy. If any of this present, go for a stool pathogen. If specific is found, go for specific treatment. Otherwise, go for empirical treatment. So this is very important thing I am highlighting. So again, anything more than severe, more than 6 hours, blood duration more than, then if there is any of this positive, you go for antimicrobial therapy. If there is nothing is there, just continue symptomatic. If needed, you can start them on therapy. So again, the same thing, I want to highlight these points again. Just a watery diarrhea, traveler history is present. Generally, if the blood temperature is less than 38, just go for the symptomatic management. And if the patient has inflammatory diarrhea, specifically any blood mucus inflammatory diarrhea, you can go for stool test and empirical antibiotic. So always remember, non-inflammatory diarrhea can be managed symptomatically. If needed, you can start them on antibiotics and antidiarrheal. Any inflammatory diarrhea, don't put them on antidiarrheal drug routinely. Anti-motility drugs routinely. If you are suspecting bloody diarrhea, inflammatory diarrhea, start them on empirical antibiotic if needed. Except in the case, I'll give the exceptions where it is not needed. One is Shiga toxin producing E. coli, other is enterohemorrhagic E. coli, and other one more thing where especially in the case of salmonella and non-typhoid salmonella also, where it showed that antibiotic treatment delayed the recovery in this patient, where the patient is not significantly sick. Just a mild diarrhea is there in the case of salmonella and non-typhoid salmonella, you need not start them on antibiotic. In other cases, even you can start them on antibiotic, except these 3 cases, you can start them on antibiotic. I'll give you the list where you can start and where you cannot start. So you can remember this thing. So always remember this slide very importantly. Any fever, blood stools, fecal WBC, immunocompromised, elderly host, you need to give stool culture and start them on empirical antibiotic. If the patient doesn't have any of this, you can then start for antidiarrheal drugs, because most of them are non-inflammatory. So this Campylobacter jejuni, generally If the patient has dysentery and like bloody diarrhea is there and sepsis is there, then you can try azithromycin in the first line of drug. C. difficile, generally you give oral previously it is metronidazole, now they are giving oral vancomycin. Any anthropathogenic E. coli, we can give any traveler's diarrhea. So traveler's diarrhea, you can generally give ciprofloxacin. So and traveler's diarrhea, I'll give you the list of what are the causes of traveler's diarrhea: enterotoxin, norovirus, rotavirus, many are there. Then traveler's diarrhea, all the possible causes, you can give ciprofloxacin therapy. This is the most important. Salmonella, non-typhoid salmonella, doubtful. So because it is mostly affecting the case of severe case and sepsis case of dysentery. Generally, routinely for mild diarrhea, you don't generally treat salmonella infection. Vidal is very non-specific. One thing, Vidal is not a very sensitive. It's just a cheaper test that is available for salmonella, because Vidal should be interpreted in the background of how much normal antibodies, like we are generally exposed to salmonella, there are normal antibodies. 1:80 is not significant in our population. Maybe 1:80 is significant in the Western population because salmonella is not prevalent. In our, we are inherently exposed to salmonella. So based on the herd immunity, what are the natural prevalence, then you need to interpret Vidal. So if you are doing Vidal test, no, always check for the rising titers. Anything more than 1:160 is there, check for the rising titers. Then only you label it as salmonella. Just anything more than 1:80, you can't call it as a salmonella, because we all of us have antibodies in them because we are regularly exposed to salmonella infection. So anything 1:80, me, if you test me also, I'll get 1:80. So that is one of the most important thing. Vidal should be always, test should always be taken with a pinch of salt. So I suggest anything more than 1:60 is present, repeat the test after 2 or 3 days. If the rising titer is there, then you suspect salmonella. Just because every patient more than 1:80, you don't label it as salmonella. That is for the Western people, not for us, because we inherently exposed to salmonella per se. So Shiga toxin E. coli also. This is one more thing, no treatment because it provokes the HUS. These are the two conditions. Salmonella routinely you don't give, any severe only you give. Shigella prevent dysentery, then you can give ciprofloxacin and tablets, 500 mg BD. So Yersinia generally not needed in the normal cases. Generally in the severe case only you generally give. It is very rare in our setup, but generally if there is only severe. These are the normal protozoal. Cryptosporidium generally we need not. For in HIV patients we give a lot of cases of cryptosporidium we see. Generally the antiretroviral therapy is effective enough. Only if the patient has a significant disease, significant after antiretroviral therapy is there, then you can give nitrogen oxide, something can be started. For cyclospora, isospora, you can give trimethoprim, cotrimoxazole can be given. Entamoeba histolytica, you generally give metronidazole. Always remember this, always start give paramomycin after that. That is 25 to 35 milligram per kg body in 3-day dose for 5 to 10 days. It will always be given. So don't forget, in all your level abscess cases, you suspecting amoebic liver, you will always give paramomycin along with, because you're only killing metronidazole, only kills intestinal tissue thing, it doesn't kill the luminal thing. Always luminal thing should also be added along with the metronidazole. Giardia, metronidazole again should be given in all the cases that if the general duodenal aspirates or culture is done. Microspora is also small bowel diarrhea. In that albendazole is given. So these are things where you can give. The exceptions always in the non-severe salmonella or non-typhoid salmonella, you need not give antibiotic therapy routinely, and Vidal test should be interpreted in caution. In Shiga toxin producing E. coli also don't start them an antibiotic. In non-inflammatory diarrheas, especially some Bacillus cereus or Clostridium, generally don't give. Them symptomatically they can be managed. And Vibrio cholera, you give doxycycline, and also in all other inflammatory diarrhea where there is some bloody diarrhea associated fever. So how do you identify this Shiga toxin E. coli? And I give you, generally they don't have fever, bloody diarrhea is the only thing. That is one of the classical hallmark of Shiga toxin E. coli, where it provokes to HUC, hemolytic HUS, hemolytic uremic syndrome. So these are the list of travelers diarrhea. We got one more question in ETSS from this. What are the list is causes? Most common cause is always enterotoxigenic E. coli, enteroaggregative, Campylobacter jejuni, Shigella, Salmonella. So you need to remember this list. Enterotoxinic is the most important cause. Shigella is the major cause of dysentery, and you need to remember this list. And norovirus, rotavirus is there, Giardia, and then Cryptosporidium, Entamoeba histolytica, Cyclosporum, acute food poisoning. These all you can, if you can remember, you can. So this norovirus associated with cruise ships also they asked us a question in the NEET assess. So this is important. Most common cause is enterotoxigenic, but most common cause of dysentery is Shigella, and in travelers diarrhea. This is for travelers diarrhea. So norovirus affects generally cruise ship workers, and Giardia generally hikers and campers where they drink unsanitized water. That is most common thing they see. So this is the list. If you can remember, I'll share the PPT and just try to remember these tables very well. So this is again mild symptoms of travelers diarrhea. You need not give any fluid, just fluid management. In the moderate diarrhea, which we seen in the first case, you can try giving the cephaloxacin, azithromycin, rifaximin, and consider fluid. If severe symptoms are there, anything more than 6, less than 3 to 4 to 6, more than 6, you can give azithromycin along with the. So if there is fever, definitely you should give the antibiotic therapy. Again, the same thing. The travelers diarrhea is one organism where they showed bismuth subsalicylate or loperamide has shown to be beneficial in reducing the diarrheal symptom along with the antibiotic therapy. You can give that, and that is one of the most important thing I want to highlight in this patient. This is again for travelers diarrhea, the same treatment part. So again, one more thing, how the post-diarrheal complication are there. So one more thing, reactive arthritis is generally seen after the Salmonella, Shigella, Campylobacter. One of the most important reactive arthritis is not seen after E. coli. So it is seen in Shigella, Salmonella, Campylobacter jejuni and Yersinia. HU is seen after Shiga toxin producing E. coli and also enterohemorrhagic E. coli. In both these patients, generally fever is not present and generally you should not give antibiotic. GBS is seen after Campylobacter infection, and sometimes chronic diarrhea is present in the few cases where the lactase deficiency or small bowel. But I'll mention about what is small bowel bacterial overgrowth and malabsorption syndrome, that is tropical. I'll again mention the chronic diarrhea part that can occur after 1% of cases of travelers diarrhea and also few cases of other any chronic diarrhea, infective diarrheas. I'll mention about the chronic diarrhea again, that's why I didn't highlight this part. So this is the one of the presentation. So this is the treatment of Clostridium difficile. As you can see, they removed the IV metronidazole. Initial treatment is always oral vancomycin 125 mg QID into 10 days, or fidaxomicin can also be given. So initial episodes, we give oral vancomycin inhalation. If it is fulminant, so what is fulminant, you need to tell me. That is one more thing. And I will also mention if you are suspecting any C. difficile or if you are suspecting any inflammatory bowel disease where there is a risk of toxic megacolon, or there is some risk of obstruction, or the patient having severe bowel dilatation, you should not give antidiarrheal drugs in this, especially in the C. difficile also don't give antidiarrheal drugs. So that is one more thing. So then vancomycin and metronidazole in the case of fulminant cases. So you can see here fulminant CD is defined as any hypotension, shock, ileus or toxic megacolon. The duration of treatment may need to be greater than 2 days. So I can say the fulminant CD is any severe with severe chronic CDI. What is severe CDI? Again, there is any leukocyte count more than 15,000 creatinine. These are all very important NEET assess question. So the severe chronic Clostridium difficile infection is anything more than 15,000 TLC count and more than 1.5 creatinine. Any fulminant along with the elevated TLC count of more than 15,000 creatinine, if there is any associated hypotension, shock or ileus or toxic megacolon, that is fulminant, where you give combination of metronidazole along with vancomycin. So after first recurrence, you can give oral vancomycin followed by tapering doses. If there is multiple recurrence, you can always treat fecal microbial transmission. This is one of the most important things. Patient at high risk of recurrent situation who are receiving all of this thing, you can go bezlotuximab, which is against the one of the CD toxin, Clostridium difficile toxins. So in this patient who are high risk of Clostridium difficile, who are already received the vancomycin, fidaxomicin, metronidazole, then you can take this bezlotuximab. So this is again the brief summary. Also always start the dehydration, likely parasitic, perform analysis, like you give likely non-infective, generalist, and for stool culture to make sure it is non-infectious, and any test for endoscopy and colonoscopy biopsy if in case of any difficulty. Likely food poisoning, probably due to the food poisoning previously affected. Generally they are self-limited, they don't require any intervention. Viral also mostly self-limited, they don't require any. You can offer loperamide in these cases. Like any viral case also you can give loperamide. They are generally non-inflammatory as mentioned. They are nausea, vomiting more, and they don't have much of fever in these cases. So this is, if you are suspecting bacterial community or travelers diarrhea, you can send for the routine culture and give an antibiotic and anti-diarrheal drug also. If it is nosocomial, you should always suspect drug related. If they especially 3 days in hospital or more than 3 antibiotic use in the 3 patients, C. difficile toxin needs to be suspected. And also so in them the empirical antibiotic persistent diarrhea, and I'll mention it again. What are the causes of persistent diarrhea? Like you should need to test mainly for the parasitic causes. And immunocompromise, I'll also mention about the immunocompromise in the HIV. I want to do a separate session for HIV associated opportunity. I'll again highlight the HIV associated diarrheas, HIV associated pneumonias. I'll do that topic. So choose if there is nothing. If you use an empirical antibiotic, a specific pathogen is grown, you can check for the specific pathogenic associated antibiotic all there. In the case of C. difficile, I already mentioned the treatment part. So that is the end of the session. Thank you.